Hello everyone. Today we are going to discuss the journal Hydrocortisone in Severe Community Acquired Pneumonia. This was recently published in Nejm. The incidence of lower respiratory tract infection is around 500 million annually, out of which more than 1.5 million adults are hospitalized for community acquired pneumonia. The mortality rate for hospitalized patients is approximately 10 to 12%. This mortality increased up to 30% for patients receiving mechanical ventilation. Pneumonia leads to intense pulmonary and systemic inflammation, which results in impaired gas exchange and organ failure. The physiological basis of glucocorticoid is that it has anti-inflammatory and immunomodulatory activities. The evidence till now suggests that meta-analysis of involving 6 RCTs showed that the glucocorticoid reduced the time to clinical stabilization and length of hospital stay without improving the survival. But another meta-analysis, which includes only the open-label trials, that suggests that glucocorticoid also decreased the mortality among patients with severe CAP. Various studies use different types of steroids with a variable dose: hydrocortisone, prednisolone, dexamethasone, or methylprednisolone. Hypothesis for this study was that early treatment with hydrocortisone reduced mortality at 28 days among patients admitted to ICU for severe CAP. This was a double-blind, randomized, controlled superiority trial conducted in 31 centers in France from October 2015 to March 2020. Adult patients with a diagnosis of pneumonia by clinical and radiological characteristics, that is, the clinical features involve at least presence of at least two of the following criteria, that is cough, purulent sputum, chest pain, and dyspnea. In the radiological criteria, chest X-ray or CT scan showing focal shadowing or infiltrate, diagnosis of CAP during the 48 hours of the post-hospital admission. The severe CAP was defined by at least one of the following criteria. So one is pneumonia severity index if it is more than 130. Second, patient on mechanical ventilation, either invasive or non-invasive, with a PEEP of more than equal to 5. Patient on high flow nasal oxygen therapy with a FiO2 of more than 0.5 and a PF ratio of less than 300. Patients on non-rebreathing mask with a PF ratio which dependent on the oxygen flow and when the PaO2 is less as per a reference table. Exclusion criteria: patients with septic shock, patients with aspiration pneumonia, patients received antibiotics for respiratory infection for more than 7 days, those who were on invasive mechanical ventilation 14 days before the current hospital admission, patients with a rapid PCR test positive for flu, patients with active tuberculosis, fungal infection, active viral hepatitis or herpes virus were excluded from the study. Patients with those who were hypersensitive to corticosteroid or those who needing corticosteroid for other reason, or patients on prednisolone of 15 mg per day or equivalent for more than 30 days were also excluded from the study. Randomization: patients were randomized in 1:1 ratio to receive hydrocortisone or placebo according to a computer generated random list with a block size of 4. The list was prepared by a statistician who was not involved in the enrollment process. Randomization was stratified according to trial center, and second is use or non-use of mechanical ventilation at the time of enrollment. The intervention: patients received the standard therapy for severe CAP, including antibiotics and other supportive measures. The choice of the respiratory support was according to the discretion of the medical team. Within 24 hours after the onset of the severe CAP, hydrocortisone group received IV hydrocortisone 200 mg per day continuous infusion during the first 4 days. On fourth day, the medical team decided whether to continue the hydrocortisone for a total duration of 8 days or 14 days. This decision was based on presence of few criteria. So these 4 criteria, like if patient breathing spontaneously, patients with a PF ratio of more than 200, SOFA score on day 4 if it is less than that of day 1, or there is high probability of discharge from the ICU on day 14. So if all of the following criteria were met, then steroid given for a total duration of 8 days, out of which 4 days of 200 milligram, then 2 days of 100 milligram, and next 2 days of 50 milligram. If any one of the criteria is not met, then total duration of steroid given was 14 days, 7 days of 200 milligram, then 4 days of 100 milligram, and last 3 days 50 milligram. In all cases, the treatment was discontinued at the time of discharge from the ICU. The control group received IV saline according to the same regimen. 2 interim analyses were planned and were performed when the endpoints were available for the first 400 and 800 randomized patients. The alpha risk was set at 0.001 for the 2 interim analyses and for less than 0.5 for the final analysis. The primary outcome was death from any cause by day 28. Secondary outcome were death from any cause by day 90, the length of ICU stay, use of non-invasive or invasive mechanical ventilation, number of ventilator and vasopressor free days by day 28. Some safety criteria were also measured, like secondary infections or gastrointestinal bleeding by day 28, daily amount of insulin requirement by day 7, and weight gain by day 7. Sample size calculation. The study was powered to detect a 25% relative reduction in 28-day mortality in the hydrocortisone group, considering 27% mortality in the control, and it was set to achieve a 25% reduction, that is to 20.25%. The required sample size was calculated to 1146 patients and it was rounded off to 1200, allowing for the withdrawals. So total 5,948 patients admitted to ICU with community acquired pneumonia were assessed for eligibility, out of which 5,148 were excluded. The most common cause for exclusion, patients with septic shock, 1200 patients. 595 had suspected inhalational pneumonia. 547 did not meet the severity criteria. 417 had a diagnosis with influenza. So ultimately 800 patients underwent randomization, 401 to hydrocortisone group, where 400 patients actually received hydrocortisone and included in the primary analysis. 399 were assigned to the placebo group and 395 were included in the primary analysis. The baseline characteristic in 2 groups were well matched. The mean age was 67. 44% of the patients received mechanical ventilation, either invasive or non-invasive, at the time of randomization. The mean PSI score, the median PSI score, so most of the patients were in class 5, 45%, then class 4, 37 or 38%. Vasopressor requirement was in 10%. The C-reactive protein median was 26.3 or 23.8. Timing of treatment. The median interval from hospital admission to ICU admission was 5.5 hours in the hydrocort and 5.2 hours in placebo group. The median interval from ICU admission to initiation of trial agent was 15 hours. The type of antibiotics administered since admission. Most common was third generation of cephalosporin, that is 77.5%, followed by macrolides, amoxicillin, amoxiclavulinic acid, and fluoroquinolone. The actual duration of treatment received was a median of 5 days. Premature stopping occurred in almost 80% of the patients. The most common cause for premature stopping was discharge alive from the ICU in 82% of the patients. 7.5% patients were died before the planned termination of the experimental treatment. In 3.8% of the patients, influenza was diagnosed after randomization. Coming to the primary outcome, so that is death by day 28, which occurred in 6.2% of the patients in the hydrocortisone group and 11.9% in the placebo group, with a difference of -5.6 with a p-value of 0.006, which is statistically significant. When the primary outcome was analyzed in different subgroups, it was found that patients who were not on mechanical ventilation, patients with age group of more than 65, female patients, patients with PSI of less than 130 and CRP of more than 15 were they favored the hydrocortisone. Secondary outcomes, death by day 90 was 9.3 and 14.7, not significant. Patients who were not on any type of mechanical ventilation at baseline, so among them 18% of the patients in the hydrocortisone group received endotracheal intubation versus 29.5% in the placebo group with a hazard ratio of 0.59, which is significant. The cumulative incidence of initiation of vasopressor by day 28 was also less in the hydrocortisone group, that is 15.3 versus 25. Coming to the safety outcomes, the incidence of hospital acquired infection, incidence of GI bleeding were similar in both the group. The median daily dose of insulin administration by day 7 was significantly higher in the hydrocortisone group when compared to the placebo group, that is 35.5% in the hydrocortisone group and 20.5 in the placebo group. That is the daily dose of insulin, 35.5 unit. The median weight change from baseline was not different in between the two groups. So in this large multi-center trial, early hydrocortisone therapy reduced the rate of death by day 28 among patients with severe CAP who were admitted to ICU, and the results also appeared to be consistent across important subgroups. This study is one of the most extensive study on this topic. The hydrocortisone therapy was initiated quite early, that is within 15 hours from the ICU admission. Patients were well matched at the baseline. There was nearly complete follow-up also occurred. The study also excluded patients with septic shock, considering the difference in the pathophysiology, and there is a largely proven benefit for steroid in septic shock group. But still it has few limitations. The mortality observed in this study was quite low than the anticipated. Here the mortality was 11.9%, but the anticipated mortality in the control group was 27%, so implying a lower severity of illness of the patients in this study. No standardized protocol was used to identify the etiological agent, and no pathogen was isolated almost in 45% of the patients. Reversibility of the steroid-induced hyperglycemia was not assessed. Steroid-induced neuromuscular side effects were also not assessed. And the treatment, the administration of hydrocortisone by a continuous infusion and with a tapering dose, it was also not supported by a high level of evidence. So to conclude, early treatment with hydrocortisone reduced 28-day mortality among patients who had been admitted to ICU with severe community acquired pneumonia. Thank you.